Welcome, everyone. We're going to give folks an opportunity to join our webinar and get started shortly. So good afternoon. We can go to the next slide. My name is Melissa Green Parker, and it is my pleasure to welcome all of you to today's event from ODP's Prevention and Focus webinar series. I will be serving as your host and moderator. But just to let you know, first launched in 2021, this webinar series was intentionally conceived for the purpose of providing a space to hear directly from prevention research experts and thought leaders whose work in driving impactful advances in the spaces of prevention research and public health is well known. And so today we are thrilled to have Dr. Hilary Slegman from the University of California, San Francisco, deliver her presentation on the challenge and promise of food as medicine. Poor nutrition is one of the leading contributing factors of death and disability in the United States. In fact, millions of Americans are affected by food insecurity and diet-related diseases. And so before we hear from our featured speaker, I'd like to welcome Dr. Christopher Lynch to say a few words, because Dr. Lynch is the acting director of the NIH Office of Nutrition Research, where he manages an awesome team of colleagues here at NIH who lead complex programs in nutrition research and promote collaboration across NIH and beyond to develop funding initiatives and workshops that focus on advancing nutrition science to enhance health. So welcome, Dr. Lynch.
Yeah, cheers. Yeah, I just only have a few brief remarks. There's a lot of, really a lot of interest in food as medicine across the federal government. And then there's so many things happening in the private sector, both with companies and .orgs, that it's been actually very hard to keep up with all the happenings. So can I have the next slide? But we're also interested in this at NIH and across our institutes and centers. For example, ODP and ONR recently coordinated 2 NIH workshops with a number of our NIH institutes, including Child Health, National Institutes of Aging, NIDDK, National Cancer Institute, and National Institutes of Child Health and Development, where and these 2 workshops included nutrition as prevention for cancer health outcomes and malnutrition in clinical settings, research gaps and opportunities. And food as medicine, is an obvious solution to a number of the issues that were raised in these workshops. We've formed an NIH-wide medical nutrition working group that's been charged with coordinating food as medicine research activities. My office is representing NIH on an interagency food as medicine work group that's been organized by the Secretary of Health. NIH also recently coordinated the development and release of a request for information, food as medicine opportunities, with 12 federal agencies showing, how many agencies are really interested in this, and with 19 institute centers and offices that are request for information closes tomorrow evening, actually. And then ONR cleared a food as medicine concept at NIH Councils of Councils, and developed a perspective that we published in the American Journal of Clinical Nutrition on food as medicine networks or centers of excellence. So we're really excited about this, and excited to hear from our speaker today. Thank you.
Wonderful. Thank you for that, Chris, for sharing your comments. The government-wide approach for integrating nutrition into health is certainly a welcomed approach that offers so much promise for positive nutritional health impact. And so before we move on to introducing our speaker for today, I'd like to go over some logistics for today's session. As you attendees joined the Zoom, audio lines were muted, and these lines will stay muted throughout the session. There will be a Q&A, question and answer session at the end of the presentation. And as stated on this slide, feel free to submit any questions you have into our chat pod and direct them to host and panelist. At any point in time, you may use the chat pod for general commentary, for submitting questions for our speaker, or to request technical assistance. We have an amazing team of ODP staff who are closely monitoring the chat and working hard to ensure appropriate engagement with our speakers today. Please note that this webinar will be recorded. An archived recording will be posted to ODP's Prevention and Focus website and made available on ODP's YouTube channel in the upcoming weeks. I saw in the chat there were some requests for slides. If you would send an email to us afterwards, we can see if we can even make the slide deck available. Okay, next slide. I know everyone is excited for today's presentation. We've had an awesome response to this event. So I'm going to pass the microphone over to my colleague, Ms. Norma Minkoff, who will introduce Dr. Seligman. So welcome, Norma.
Hello, everyone. Dr. Seligman is professor of medicine and of epidemiology and biostatistics at the University of California, San Francisco. Her work focuses on food insecurity and health outcomes across the life course, with a particular interest in programs and policies that can simultaneously support food security and better health. She has directed the Nutrition and Obesity Policy Research and Evaluation Network in partnership with the Centers for Disease Control and Prevention for the last 8 years. Her team runs Vouchers for Veggies, a large produce prescription program. She also directs the UCSF School of Medicine's National Clinician Scholars Program. I would be remiss if I didn't mention that Dr. Seligman was a featured speaker during the ODP's 2022 Pathways to Prevention workshop on nutrition as prevention for improved cancer health outcomes. It's great to welcome you back. Here's Dr. Seligman.
Well, thank you so much to NIH for giving me the opportunity to talk today about food as medicine. And I already see some great questions coming into the chat box. I'm going to talk about both the challenges and the promises of food as medicine and give you a taste of a field that I think is moving very rapidly. So as Melissa indicated at the top of the hour, 1 in 10 US households experienced food insecurity in 2021. And the USDA divides these households into the 6.4% of US households with low food security. And as a general rule, these households have had to decrease the quality of their food because of a constrained food budget. But the quantity of food was generally sufficient. And this is because healthy food in the United States tends to be more expensive than less healthy food. The other 3.8% of US households experiencing food insecurity report what's called very low food security. And in these households, both the quality and the quantity of food has to decrease in order to meet a very, very low food budget. I put this slide of the trends and the prevalence of food security and very low food security up because I want to call attention in particular to what happened in 2020 and 2021 when talk about food insecurity and massive increases in rates of food insecurity was very, very prevalent on our TV sets and in our podcasts and radio feeds. But what we see by the official numbers is that food insecurity rates stayed relatively stable. And I want to call attention to that because I think we need to be aware in this moment of how much we have policies and programs that really work to address food insecurity in the United States. And we know how to implement those policies at scale. The pandemic has given us some really excellent insight into how to do that. Food insecurity is likely an important driver of health disparities across the United States, mostly because of these changes in dietary intake, but also through mental health and behavioral and potentially even inflammatory pathways. This slide shows you disparities in food insecurity rates by race using the categorization that the USDA provides in their official numbers that are released every year. And what you can see is substantially higher food insecurity rates in Black and Hispanic households, driven, of course, by underlying disparities in structures and systems. I want to call attention to the fact also that there are people missing on this slide: Native American populations, Asian American, Pacific Islanders, Southeast Asian populations. In some cases, there are very, very high rates of food insecurity, but we aren't regularly tracking and monitoring those. So I want to start contextually in a place where I know many of us are very familiar, and that's what we might call the misalignment between healthcare and social care in the United States. What this slide shows here, and I'm sure many of you have seen this before, is that if you look at all of the US spending on health and social care compared to other developed nations, the US spends much, much more of their GDP on healthcare compared to social care, compared to these other countries. And this fact and the very high amount of money that we spend in the US on healthcare has really pushed healthcare organizations to start thinking about how they might be part of this misalignment and how they might start moving a little bit upstream. Now, let me be very careful when I say moving upstream, that we're not moving totally upstream towards addressing community conditions or social determinants of health. We are not yet at a place, I think, with food as medicine momentum, that healthcare organizations are seeking to change laws, policies, and regulations that create these underlying structures that create food insecurity to begin with in the United States, or that put Black and brown households at increased risk for food insecurity. But healthcare organizations have been very interested in moving what we might call midstream, or moving towards that by addressing acute social needs, like, for example, the need for food. And this is often in response to screening for social determinants of health. So this is an outdated slide, and so it was originally released by the USDA. I don't know that they still use this language, but I really like it because many of you have heard recently a shift from the construct of food security to the construct of nutrition security. What does nutrition security mean? Well, there really isn't a consensus definition. But what we do think is consensus is that nutrition security has some component of food security in addition to diet quality and equity, that these three constructs are each important parts of nutrition security. And you might think of it, although this is very oversimplified, that food security has an emphasis on access to sufficient calories, whereas nutrition security has an emphasis on access to the right calories. or calories that are adequately healthy for the prevention and management of chronic disease like obesity, diabetes, heart failure, and other cardiovascular disease. So this is the milieu in which the food as medicine movement has really captured a lot of momentum. And there are many different ways in which food as medicine is defined and understood by people. So I want to be very careful to start out with, what do we mean by food as medicine? And responding to a question in a chat box, many people use the term food as medicine synonymously with food is medicine. So the Aspen Institute released this definition that I'm going to use today. Food as medicine is the integration of a specific food and nutrition intervention in or in collaboration with the healthcare system. So it's bringing together two sectors, food and nutrition and healthcare. And a food as nutrition program or intervention is generally targeted towards people with or at high risk of a certain health condition, often a diet-related health condition, or targeted towards people with or at high risk of food insecurity. So the ecosystem of food as medicine interventions has developed over, I would say, the last 10 years and has created a bit of a complicated ecosystem. So I like to think of this ecosystem in three large buckets based on who is really the primary driver of those interventions or programs. The first is on-site programs, and these programs are often led by the healthcare partner and take place in the clinical setting. So examples of this might be co-locating a food pantry in the clinic, particularly a food pantry that emphasizes healthy and nutritious foods. It may take the form of a mobile food distribution in the clinic. For example, a truck stocked with healthy food comes to the parking lot outside the clinic once a week or once a month. Or it may take the form of embedding a SNAP eligibility worker into the clinical setting who can support food insecure patients who are eligible with SNAP with completing their application. SNAP refers to the Supplemental Nutrition Assistance Program, the largest USDA program, and it provides money that can be used for food at grocery stores and farmers markets across the US. The second bucket is community programs, and these programs are generally led by community-based organizations. And the healthcare entity generally refers patients into this community-based ecosystem to receive the food support. So these may take the form of medically tailored meals or groceries that are provided by a community organization, a food pantry, or other parts of the charitable food system, and produce prescriptions, which we'll talk about more in a minute. And then there are, of course, the other federal nutrition programs like WIC, which I'll come back to in just a second, and many other federal nutrition programs. And if you're embedding or referring a patient into these programs from the clinical setting, again, I think of that as a food as medicine intervention. So this is my own personal opinion. If I look at that definition of food as medicine interventions as being a food and nutrition intervention in or in close collaboration with the healthcare system, I think of WIC as being the largest food as medicine program in the United States. Why? Because WIC has a referral from the healthcare provider. It tracks and monitors health outcomes, and it provides access not to any foods, but a specific basket of healthy and nutritious foods. And the importance for me of thinking about WIC as the largest food as medicine program in the United States is that I often get the question, can food as medicine programs be scaled? And I say, yes, they can. And the WIC program has really proven that. The second question I often get is, can food as medicine programs impact short and long-term health outcomes? And again, I say, yes, WIC has proven that. And we will dive into that a little bit more. For those of you who are unfamiliar with WIC, WIC provides benefits for specific healthy food products to pregnant and postpartum women and to children under the ages of 5 who are also low income. So here's the theory of change that, that many of these programs are developed under the assumption of impact. This is how these programs are assumed to have their impact. That in the clinical setting, we can screen patients for food insecurity. If they have a positive screen, we would refer them to some kind of food as medicine program. And if they are enrolled and start to receive benefits, they would improve their diet quality, their food security, and their satisfaction with their clinical care. And that would result in a downstream improvement in health and utilization outcomes. And in truth, this looks quite lovely in this slide, but it's proven to be very difficult. And in many cases, it's because we don't have the systems in place that allow these referrals and this enrollment to happen as easily as it would if you, for example, screened positive for in your FOBT and needed a referral for a colonoscopy or something that would stay entirely within the healthcare system. And that's predominant, or it's for many reasons, but some key reasons are that data transfer between community-based organizations, healthcare, and the food sector, groceries and other retail organizations has been very, very difficult because we're dealing with health information that's governed by HIPAA requirements. Data tracking of participation within the electronic health record has also been very challenging. The third major challenge with this is that community-based organizations don't always have the capacity to provide food how, when, where, and at the price that healthcare desires. They're also a very constrained system that's working often under grants or under individual donations. And finally, there's great fragmentation of the ecosystem outside healthcare, and I'm going to go into that a little bit more. So there's two ways in which the system fragmentation plays out. On the left side here, you see the very many different organizations that healthcare might have to communicate with in order to develop a real functioning food as medicine system. There's people in food retail or organizations, supermarkets, big box stores, corner stores, convenience stores. They may need to be communicating and collaborating with farms through CSA boxes, for example, or farmers markets. They may need to be collaborating with other community-based organizations in the charitable food system, like food banks and food pantries, like home delivered meal providers, like mobile markets. And this collaboration across sectors is quite difficult. The other way in which we have system fragmentation is that there are a lot of different food as medicine programs, as I talked about on a previous graph. And what you need today as a patient may differ from what you need tomorrow. So for example, medically tailored meals are a high cost, high dose treatment that's really good for people who are frail, who have a high burden of chronic disease, because the food is already prepared when you receive it. Medically tailored food packages require you to do cooking yourself. As we move down this scale towards nutritious food referrals or produce prescription programs and population level healthy food programs, what we see is that the interventions become lower cost, but they also require people to put in their own skills and resources and work, so they might have to do their own shopping and their own cooking. And so right-sizing the intervention for your stage in life has been really quite challenging, because people need to be able to move across in between these programs as their needs change. And in order to be really cost efficient in this system, we have to be able to move across easily. So the first question I want to take on today is, what do we know about the impact of food as medicine programs? And I already told you that I think of WIC as having the strongest evidence across numerous different health outcomes, short and long term, and also non-health outcomes like academic performance. And SNAP is grayed out here because I don't consider it a food as medicine intervention. But I do want to say that there's very strong evidence that SNAP can also improve health outcomes. Among the others, the greatest evidence is for medically tailored meals programs. And a lot of the reason why these have the strongest evidence behind them is because they are often provided, again, to people who have the highest burden of disease, and therefore they tend to have hospital admissions and high health costs, and it's easier to see an impact in a short period of time. And so medically tailored meals programs have been studied, and this is not quite up to date, but almost, through at least 10 studies, including 2 randomized controlled trials that show that they can reduce hospital admissions and readmissions, lower medical costs, and improve medication adherence. Medically tailored groceries has had very few studies of their impact, but some emerging data suggesting that they improve food security. Produce prescriptions have much more data. They've been studied in many different contexts and shown changes in improvements in diet quality, food security, and diabetes outcomes. But most of these studies have been small, pre-post studies without a control group. And then on-site programs, again, very little data for their impact. Another way to think of this is from the perspective of healthcare. So this systematic review looked at 29 different interventions that were implemented in healthcare. And I'll direct your attention to the right side of the graph where you see, the right side of the slide where you see the impact. And what you can see is there's pretty consistent improvement in food security status and in health behaviors. But as you move more distally towards the health outcomes or the cost and utilization outcomes, data becomes a little bit more mixed. So the next question you might ask is, why is the data so limited? And I'm going to give you a couple of reasons, but I would encourage people to think about reasons in their own work or in their own communities. So food as medicine programs, because of the way that they are currently being funded for the most part, and we can get more into policy opportunities during the Q&A if people are interested, almost all programs right now are reaching a very small number of people that may not be suitable for examining health outcomes, utilization, and cost because they're just not offering sufficient power to do so. They're also often offering a relatively small dose and duration of services. So for example, if you receive a produce prescription that offers you 6 weeks worth of vouchers that you can redeem at a grocery store, and each week you have $10 worth of fruits and vegetables, a $10 benefit once a week for 6 weeks is very unlikely to have an impact on health outcomes, utilization, and cost. Many programs are single site, so they don't necessarily have applicability to the field as a whole, and you need a lot of data to show an impact for these kinds of studies. I won't get into this given our audience, but I do want to emphasize that nutrition programs in general are better at prevention than at treatment. They are expected to have an impact over a long length of time and are generally proven by their small effect over a large number of people. And that is really where I think that our field needs to be moving. So where are the opportunities? Most of the next slides refer to produce prescription programs because there's a lot of leadership and momentum in this space right now. But I do want to give the caveat that these are not necessarily the best programs for every clinical setting or every community, but almost all of the concepts are relevant to the other kinds of food as medicine interventions that I have been mentioning. So the first opportunity for the field that I want to mention is access to large amounts of data. So what you see on the right here is a chart of the produce prescription programs in the US. Just through 2020, the number of produce prescription programs has increased tremendously even since 2020. And so I want to say that this could be updated tremendously again. However, produce prescription programs have been implemented across the United States many of them with funding from the USDA's Gus Schumacher Nutrition Incentive Program, which is generally referred to as GUSNIP. One of the opportunities is in sharing metrics across all of these smaller sites so that we can pull all that data together and see outcomes for a much greater number of individuals enrolled in produce prescription programs across the US altogether. There also may be opportunities within large health systems that have a single electronic health record. And there's been a lot of work on implementation of programs through the VA, through the Indian Health Service, and through other integrated health systems. And I do want to mention here that the release of the Biden-Harris National Strategy on Hunger, Nutrition, and Health just 6 or 8 months ago is really catalyzed a lot of energy around implementation of food as medicine programs within federal health systems like the VA and the Indian Health Service. And then there are opportunities to large amounts of data from health insurers that might enroll and have access to claims data across millions of people at one time. The second opportunity for the field I want to mention is that there's been some really good efforts in using microsimulation modeling to try to understand if we have the expected impact on food security and dietary intake, what would be the downstream impact in terms of cost to society and long-term health outcomes. And this is one example of many, this one from the Friedman School of Nutrition at Tufts University, that essentially demonstrates that if you covered 30% of a healthy food basket, and healthy foods were defined broadly as fruits, nuts and seeds, vegetables, whole grains, seafood, and plant oils, that you might expect the program to be cost effective over 5 years and lead to $100 billion less in healthcare utilization over the population's lifetime. And this was primarily driven by a decrease in cardiovascular events, but also saw a pretty substantial increase in diabetes cases that were prevented or postponed. So I want to move to some opportunities for individual programs. And I will say this is my own personal opinion. And there are many people who read the scientific consensus a little bit differently than I do. The way I see this field is that we've already proven through many, many decades of research that nutritious diets lead to better health, that increased fruit and vegetable intake lead to better health, and that food security leads to better health. And there's a lot of interest and drive towards showing that each individual food as medicine program is able to lead to better health. And from my perspective, our emphasis and our energy really needs to be on showing the extent to which food as medicine programs can increase fruit and vegetable intake and support food security. Because if we're able to do that with fidelity, to do it cost effectively in a way that can be scaled across the US, I think if dose and duration are sufficient, and again, implementation is at scale, we will see better health, and that is backed by the consensus of scientific data. I mentioned briefly the opportunity for sharing metrics in food as medicine programs across the US. I do want to mention that for individual programs, there are opportunities to share metrics to use metrics for your own program that allow you to compare with food as medicine interventions in other settings and places. When we have these shared metrics, we are able to look at more participants across more sites. So one that I would call attention to is from the Nutrition Incentive Hub that is run by the GUSNIP National TA and Evaluation Center, NTAE. And if you look at their website, you can see their required metrics and their recommended metrics for food security, fruit and vegetable intake, SNAP participation, program satisfaction, health status, so that you might align your evaluation with evaluations taking place across the US. And finally, in terms of opportunities, I would be remiss if I didn't say that really, if you believe this, that we really need to think about how can we best increase fruit and vegetable intake and increase food security. We really need to make sure that our efforts aren't entirely focused on effectiveness, but are also very deeply thinking about and evaluating reach, adoption, implementation, and maintenance are the other 4 components of this implementation science framework that many of you are aware of, called RE-AIM. And so, we need to understand, who are these interventions reaching? How are they reaching them? Are we reaching the most vulnerable people, or are these programs going to reach people who are already the best resourced, in which case they may increase rather than decrease health disparities? I will skip effectiveness because I think everybody on this call is probably really good at examining effectiveness. And what I'm more interested in is adoption. Is this too challenging for clinics to participate in? Are there electronic health record challenges that clinics can't overcome? Are there differences between the clinics that participate and those that do not? And one of the things that this is particularly interesting to think about in the context of is rural-urban communities. So for example, if you live in a rural community where food access is more difficult anyway out in the environment, are they not able to use a produce prescription program because there's nowhere place to redeem the voucher? And if so, are these programs creating disparities between rural and urban communities that, with more thoughtfulness, we might be able to address? Implementation challenges. Are we able to implement these programs with fidelity in many different geographies? How much does it cost in terms of time and money? And maintenance, how are we able to sustain these programs over time? So there is enormous momentum building here. It is building because the healthcare sector is very interested in them. It's also building because there is ongoing policy creation that is supporting much more broad scale implementation. Some examples of this are Medicaid waivers that are allowing food and nutrition services through, for example, medically tailored meals or medically tailored groceries to be reimbursed through Medicaid. And this may take the place of, this may be 2 kinds of waivers. You may have heard of Medicaid 1115 waivers, or you may have heard about Medicaid in lieu of services. Both of these are creating opportunities for states to allow food as medicine programs to be reimbursable, which is expected to give many, many more people access to food as medicine interventions, and is also creating enormous incentives for private partners to jump into this space and to provide food as medicine services to patients as well. So I want to close us off by hearkening back to that previous slide of, are we really starting to address social determinants of health upstream, or is this a midstream intervention? And I want to use for this, with thanks to Laura Gottlieb for helping me to understand this, I want to use the framework of the National Academies of Science, Engineering, and Medicine 5 A's framework for strengthening social care integration. And they divide their efforts into 5 A's, 2 of which are focused on individuals, adjustment, and assistance, 2 focused on community, alignment, and advocacy, and awareness, which spans both. So what on earth does this mean? And in particular, what does it mean in the context of food insecurity? Well, in the context of food insecurity, awareness would mean that all patients are screened for food insecurity in the clinical setting. We have aligned upon the best practice screening tool. It's the 2-item hunger vital sign measure. Adjustment, or what's also called social risk informed care, would mean tailoring our care of patients in the clinical setting to address the food insecurity. So for example, adjusting insulin doses to avoid low blood sugar when someone's food budget is insufficient to access an adequate quantity of food. Assistance would be social risk targeted care. This is trying to address risk by moving upstream, again, enrolling patients in any of the food as medicine programs we started today. But then what does this mean at the community level? Well, one is trying to align the healthcare setting with other sectors outside of healthcare and supporting investment in those programs so that those partnerships can be successful. So it may mean co-locating food programs in clinical settings. It may be partnerships between the healthcare system and a community-based organization. This may mean sharing data about health disparities with a food security community organization or a food policy council. And finally, advocacy is really thinking about the ways that healthcare may be positioned to more formally support the social determinants of health. And one example of this may be advocating for more streamlined enrollment into SNAP so that patients could more easily enroll. Or my favorite one, supporting more streamlined enrollment simultaneously into Medicaid and SNAP. So I want to conclude here by saying that I consider WIC a proven, scalable intervention that has a positive impact on health outcomes. And the question is, do we want to expand these food as medicine programs beyond pregnant and postpartum women and children under the age of 5 and allow many different populations to take advantage of the better health outcomes that can come from them? There is tremendous momentum towards implementation and evaluation across the US. Much of this is being driven by the USDA's BESNP program, but there are also many other funders that are interested in this implementation. But the evaluation has proven very difficult. And this is particularly true in the pediatric setting, where we're often trying to show that these types of programs can prevent outcomes that are decades in the future. We just wrote a JAMA Peds editorial about this if you want to think more about equitable health outcomes for pediatric populations. So this is from my perspective, resist the temptation to reprove that nutritious food and food security are good for your health, because we know that, and there are so many other really important outstanding questions, and they center on all of the elements of the RE-AIM framework, not just effectiveness, and using shared metrics when we can so that we can examine those effectiveness outcomes more easily. And finally, we need and are awaiting that single large rigorously conducted trial, although there are many groups that are interested in doing this. And we really need these implementation science approaches so that we know what best practices are. Finally, I will encourage you, if you're interested in learning more about or joining the Nutrition and Obesity Policy Research and Evaluation Network, we are open to anybody who is interested in working on nutrition policy research and evaluation. So please email us or check out our website. We would be happy to have you. And with that, I will turn it back over to you, Melissa.
Wonderful. Thank you so much for this awesome presentation, Dr. Seligman. The chat is blowing up, the hearts are coming up, the hands are clapping. So thank you. As you all think about your questions, I want to just ask you to save the date. We have another wonderful presentation coming your way on August 17th. And the topic will be on midwifery. So more information coming soon. But next slide, we are now going to move to the question and answer portion of today's session. Attendees, continue to put your questions in the Q&A pod directed to the host and all panelists. And I'm going to start with this question because this was going to be one that I had opened with, but like great minds think alike. It says, can you speak to the challenges of culturally appropriate approaches to food as medicine?
Yeah, that's a great question and something that people are thinking about a lot. So I will say there are two sides to this. One is that one of the tensions in the field is between using approaches like a produce prescription program where you take your voucher, your debit card to the grocery store or the farmer's market and you choose your own foods. And that almost guarantees cultural competency unless you don't have stores in your vendor network that stock the foods that you're interested in. But other than that, it ensures cultural competency because you're choosing your own foods. You're also paying retail prices for them. And so on the other hand, this tension is between other models that, for example, allow you a medically tailored grocery bag, or you're in the food pantry, which tends to be smaller, and maybe there's less choice sometimes. And these models, there have been a lot of efforts to try to ensure that there are culturally appropriate options available. But this is one of the reasons why I'm a big fan of produce prescription programs. And I think from a cultural competency perspective, they are often the best.
Great, thank you for that. Another question that's coming up a couple of times in the chat is, do you have recommended tools for screening food, for screening for nutrition insecurity, not just food insecurity? And kind of combined with that is what tools are available for measuring food insecurity. And I just saw another question about even tools available to evaluate the security. So several questions in one, but wanted
Great.
to
So there has been a lot of alignment for food insecurity screening on the 2-item hunger vital sign. And this is the tool for screening for food insecurity that is already embedded in most electronic health record systems. You often have to look for it, but it's generally in there as a 2-item. A number of social risk screening scales include food insecurity in combination with housing insecurity, transportation needs, utility needs, et cetera. And these often use a 1-item measure of food insecurity. But if you really want to be screening just for food insecurity, the hunger vital sign is the way to go. Nutrition security is in evolution. We are at a place where the term is still relatively new. There is not necessarily a consensus on the definition or on the way to measure it. And a lot of this stems from the fact that measuring dietary quality is really, really difficult. And we don't really have clinical tools at this point in time that are good at measuring dietary quality. Access to healthy food, and it is maybe something that we can get at in the clinical setting. And so I will just answer the question by saying there are maybe 2 opportunities. One is a nutrition security scale that is being worked on with the Los Angeles Department of Public Health, the Tufts Friedman School of Nutrition, and Kaiser Permanente. And I think if you Google it, you can find access to that nutrition security scale. It's excellent. There's another nutrition security scale that has been developed by the Gretchen Swanson Center for Nutrition. Also excellent. I encourage you to Google it and look for those. Both of the Tufts one is about 2 items, and the Gretchen Swanson one is, I think, 6 items.
Excellent. Thank you for those resources. So another attendee asked, can you clarify if the data for MTM focused on individuals who consumed 3 MTM daily or were supplemented with 1 or 2 MTMs per day?
The largest and the best randomized control trial of medically tailored meals, I think, was full meal replacement, or 21 meals per week. And it's an excellent question because many of the reimbursable food models are defining a medically tailored meal intervention as something closer to 10 to 14 meals per week. So again, we're getting into that place where dose and duration is really important. And do we really understand the impact of the dose and duration of services that are actually being provided in communities, not just in our clinical trials? That's a place that we really have to put some effort over the coming years.
Okay, great. Another question, is there a way to increase the price of unhealthy or non-nutrition or nutrition kind of dense foods, non-nutrition dense foods, and decrease the price of healthier or nutrition dense foods? Like do like a reversal here?
Yeah, well, there are a couple of ways to think about this. One is that is essentially the reasoning behind the produce prescription model, that you are reducing the price of produce, of fruits and vegetables. In my own program that I run, Vouchers for Veggies, we're called Eat SF in San Francisco. It is a complete subsidy, so you don't have to pay anything out of pocket. Some of these programs are partial subsidies where, for example, it lowers the cost of your produce by 30 cents for every dollar, for example. So that's one model, the produce prescription program model. There's also nutrition incentives, also funded by the GusNet program, which I talked about previously, which allows people who are enrolled in SNAP to get subsidies on their own purchases of fruits and vegetables in farmers markets and grocery stores. And so that's another way that food has been subsidized. And then the other ways that have been tested to increase consumption of healthy foods by lowering prices are, for example, in worksite settings, where there has been pretty good evidence to show that if you lower the price of healthy foods, demand for them goes up. We've also seen the opposite of this with sugar sweetened beverage taxes, where if you increase the prices of unhealthy foods, purchases and consumption will go down. Although, of course, the data is not 100% clear. And I just see this coming in. Can I just quickly respond to the question about billing codes? Because
Sure.
This is a big issue for healthcare providers, is having the opportunity to bill for services by having billable codes, and there's a lot of effort here. Z59.4 allows you to code for food insecurity in the clinical setting, and so yes, you can use that code. It is not reimbursable on its own, but it does lead towards social complexity. It does qualify for increasing social complexity of the visit. And in states where you can bill for services, for medically tailored meals or produce prescription programs, for example, those codes can justify those services.
Okay, great. So continuing to hit the chat is busy. Whew, very, very exciting topic. Is there any data to show which sex and or demographic population were more likely to enroll in these programs?
Let me start with my own anecdotal evidence and say that what I see is that food as medicine interventions are being driven most by funders who have priority populations, or for example, community health benefits dollars that have priority populations. They may be people with diabetes, they may be pregnant women, and these programs often are developed specifically to reach particular clinical populations. That's been really challenging as someone who works in this field a lot, because priority populations change. And so the outreach efforts might really have to change if your funders suddenly are less interested in diabetes and more interested in heart failure readmissions, for example. And then the other point I would like to make is that any program that is implemented without specifically intending to reach the most vulnerable and lowest resource populations is not going to reach the most vulnerable and lowest resource populations. And that is a general tenet of epidemiology that we need to really understand. And so our reach into these communities is only as good as we are able to tailor our programs to these communities. The GusNet Produce Prescription Program has much more data about the general reach of these programs and who they're generally reaching, but I will say, in general, they're reaching people on Medicaid, they're reaching low-income people, but they may not be reaching the lowest resource people. And again, we need more data to show that.
Okay, kind of a tangential question is, how do the researchers even know if people actually ate the meals delivered to them?
Great question. Many studies ask those questions specifically. And a lot of the studies that have been done do measures of diet quality either through 24-hour recalls or through food frequency questionnaires. And in some cases, if they're only offering access to fruits and vegetables, through dietary screeners that are only looking at intake of fruits and vegetables. I think what the question may be also alluding to is the difficulty measuring dietary intake well, particularly in communities where English is not the first language, in communities where doing hour or 2 hour long interviews is not really very feasible. And so that does make it more challenging to do evaluations of these programs in very low resource communities.
Okay, thank you. This one says primary care is overloaded now, and so scale with these programs is really a challenge. This person said they're even struggling just to get people into the diabetes prevention program. Is there something different needed to get FIM adopted by clinical teams?
Yes, I appreciate that question a lot because it gives me the opportunity to say something really important, which is that, at least anecdotally, my observation has been that food insecurity, positive questions to the food insecurity, positive answers to the food insecurity screening questions are actually the lowest when they are administered by the healthcare provider. They're a little higher when they're administered by the nurse, even higher when they're administered by the nurse's assistant, and maybe even highest when they're administered by the front desk staff. And why is this? I think because there are inherent power differentials in a clinical setting that no matter how much effort goes into equalizing those power dynamics, it's just very difficult to do it. So what I like to say to primary care providers is it's really important that you follow up on a positive screen by doing some of the things that we talked about on that 5A slide, adjusting insulin doses, talking about healthy dietary substitutions that are budget neutral, that don't cost any money. But you don't have to be the person administering the question. And actually, it probably shouldn't be you administering the question. The second thing I want to call attention to is that SNAP is an entitlement in the United States, and you shouldn't even be, there doesn't need to be a connection between supporting people in enrolling in SNAP and reporting being food insecure. My recommendation is that a patient who isn't enrolled in SNAP should be referred to SNAP, and you don't, if they're eligible or you think they're eligible, you don't even have to ask the food insecurity questions because they should be on SNAP anyway. And finally, I would say that there are a number of ways that administratively your healthcare system may be able to predict who's food insecure. And there's been a lot of good work at Kaiser Permanente in Colorado to develop some algorithms that suggest, for example, if you're dually enrolled in Medicare and Medicaid, particularly if you have a chronic disease, your risk of being food insecure is so high that they don't ask you the questions. They just move on to having ancillary staff supporting you and enrolling in a food as medicine intervention.
Excellent. Thank you for that. Looking at the time, I think this is probably going to be the last question, but can you speak to FIM models that are also looking at mental health outcomes?
Oh, I wish I could. Let me say that there have been some qualitative and quantitative studies that, well, there's been qualitative studies that suggest that medically tailored meals in particular can have a profound impact on mental health, particularly by decreasing worry about where the next meal is going to come from. There's also quantitative data to suggest that depressive and anxiety symptoms can be reduced in the context of ongoing, very stable access to food as medicine resources. There have not, as far as I know, been any food as medicine studies that examine the impact of a food as medicine intervention on mental health outcomes more broadly than that. An important gap for us to be filling.
All right, this one came twice. I will throw this one in here too. And it is really, can you just share any comments about translating health-based metrics to monetary metrics, especially as it relates to incentivize government and congressional funding for scaling up the FIM efforts?
Well, here's where we get into these microsimulation models where we can look at what healthcare costs are across the entire population for people, for example, who are enrolled versus not enrolled in a food as medicine intervention, and try to predict out what their long-term costs are going to be. What we do know from direct data from the National Health Interview Survey and from MAPS is that if you are living in a food insecure household, your annual healthcare expenditures are about $1,800 per day higher than would be expected if you were living in a food secure household. We also know from similar data sets that if you are enrolled in SNAP, your predicted annual healthcare expenditures go down compared to eligible people who are not enrolled in SNAP. And so that's the kind of data that allows us to sort of extrapolate into what might be the impact more broadly of food as medicine interventions across cost in the entire population. But better studies need to be done here as well, and so an important area for future research.
Thank you, thank you. There were tons of questions. We are going to do our best to reach out to Dr. Seligman to see if she'd be willing to provide written responses to those who weren't elevated today. But thank you again, Dr. Seligman, and to Dr. Lynch for elevating this very important topic. And additional thanks to all of you for taking the time to join us today. As been stated, we will have a recording of this webinar archived shortly. If you have any questions about the series, today's presentation, questions that you would still like to see answered, we have put, Dr. Seligman shared an email address that has been put in the chat, but you can also reach out to us directly at our prevention and focus at nih.gov email. We thank you for attending. We look forward to seeing you in August at our next Prevention and Focus webinar. So thank you all very much.